So welcome everybody to the Women in Research webinar. My name is Sara Birkhoelzer. I'm a cardiology trainee in the south of England and co-founder of Global Women in Cardiology Early Careers. It is my honor to welcome you all to our first joint meeting with the Pink International Young Academy of Cardiology team. The reason for the underrepresentation of women in cardiology are multiple. Our primary objective for the collaboration is to improve female representation for both cardiologists and patients. Our focus is directed primarily on five major issues we identified: the impact on the personal and professional and academic life of female cardiologists, and the personal academic implications for female patients. Women in researchers and clinical trials are the predictor for the enrollment of female participants. So the engagement of women in academia has the potential to offer a wide range of opportunities for female cardiologists, ranging from speaking, networking, and participation in research trials, resulting in a higher professional visibility and the possibility of career advancement. As trainees and early career women in cardiology, our aim is to raise awareness about the underrepresentation of women trainees, encourage women to pursue cardiology, and influence subspecialty selection in academic pursuits. And now I would like to hand over to Sara Moscatelli.
Welcome, dear friend and colleague. My name is Sara Moscatelli. I'm a fellow at the Royal Brompton Hospital in pediatric cardiology. I'm very happy to be here and to have the honor to introduce this webinar about women in research. But first of all, I want to really thank you, Global Week Early Career, so Sabeeda, Sara, and Aaysha. They've been amazing mentor in organizing this event, like older sisters for us, Pink. So thank you very much. And the last thing, I would like just to say a few words about Pink International Young Academy. We have a group of female cardiologists that really would like to help the young cardiologists in their career through events like this that have the aim to be to mentor them. And we are really looking forward also to engage in this, our male counterpart, always with the same aim to mentor the young female cardiology. So thank you very much. And I will leave the word to Professor Tugbe Kemaloglu, that has been a great friend and also mentor for me in this IYAC experience. Thank you.
Thank you, Sara. My dear colleagues, and welcome to our webinar. I am the coordinator and co-founder of International Young Academy of Cardiology, Tugbe Kemaloglu from Turkey. I am very happy with this meeting as a result of collaboration between our subgroup Pink IYAC and the Global Women in Cardiology. I have no doubt that we will learn a lot this evening from the worldwide women experts, and I would like to introduce our first speaker, Chiara Bucciarelli Ducci. She is a senior in cardiology at University of Bristol and honorary cardiologist at the Bristol Heart Institute, United Kingdom. She was awarded a PhD in cardiac magnetic resonance at National Heart and Lung Institute. Dr. Bucciarelli is the past European Association of Cardiovascular Imaging Vice President and Chair of the Cardiac MRI section. She is a consultant for the International Anatomy Energy Agency and the European Medicine Agency. Since 2020, she is one of the deputy editor for European Heart Journal. In addition, she is an editorial consultant for JACC Cardiovascular Imaging and in the editorial board of Circulation Imaging and the European Heart Journal Cardiovascular Imaging. Dr. Bucciarelli, really very impressive career, and I can't wait to listen to you.
Yeah. Thank you so much, Tugbe, for the introduction, and it's really a pleasure to be here this afternoon with you, this morning, with you, and to share some thoughts about research projects and how to go about this and how to put ideas into concrete study design and study proposals. So yeah, so delighted to be part of this very prestigious group of speakers and among so many colleagues and friends. So that's my topic, research projects. And so first of all, I want to start, why do we want to do research? I think it's important, so taking a step back And my motivation, but I think a motivation of many of us, is to improve the understanding of cardiovascular disease in our specific field of cardiology, cardiovascular science, but also to improve patient care. I think those are the most important motivations. So we live in the present, but we want to design a future and improve things. And so that's really the motivation. So my advice to this group is really to understand, understanding your motivation for doing research. It's not an easy business doing research. I mean, it has a lot of excitements, but it's also hard work. And sometimes I'm sure we're gonna hear from the other speakers, can be depressing, it can be hard, but never be let down and continue to fight, but you need to be motivated. Hence why you have to have clear why you want to do it in the first place. The steps involving in doing research are many. First of all, you need to have a motivation, as we said. And secondly, you need to have a topic of interest. It doesn't need to be one, it can be more, but for the sake of this, let's focus on one in particular. You need to know the literature on that specific topic really inside out. And that's really a must. And that's absolutely the first step before you even think about doing a research project. Secondly, you need to identify a gap in knowledge, and you can only do that if you know the literature inside out. And then you develop a research idea around that gap in knowledge, because the whole point then in doing the research is to advance the knowledge. And so having a gap in the knowledge is exactly what you need to find. You develop your research idea, you then need to fund the study, run the study, present and publish your study, and as a result, you have contributed to the literature. So I will be focusing on this, how to develop a research idea, and the rest of the speakers will discuss the other points. But I've included in my talk also points 1 to 4, because I think they are propedeutic to develop a research idea. So conceptualizing the idea, what does it mean precisely, conceptualizing the idea? Well, it means that you need to select a topic and you need to formulating a defensible and researchable research problem. That's what this process it's all about. And I hope I'll try to explain it simply, and I hope I'll succeed, because if I don't, it means I don't understand it myself, and hopefully I do. So fingers crossed, this talk will be clear. So the way I see it is really a cycle from starting having a curiosity. I mean, at least in my case, sometimes I say, I wonder whether, such and such, and in a particular topic of interest. Then I start reading the literature and study and getting to know the literature. Sometimes I find the answer to my curiosity in the literature already, and that's it, which means I don't have to pursue that particular research interest because somebody else has done it before and it's clear in the literature. If it's not clear, or if those answers are incomplete, then there is a gap in knowledge. And so I can pursue that particular idea. And then I need to frame this idea in a more coherent way. I need to see if it's a valid idea. I need to design it properly. And then I deliver it. And that way my curiosity and my interest in the topic is being fulfilled, essentially. And hopefully that of more people, because people will be reading your papers. So more people will be interested in the same topic. So how to search for an idea if you don't have one? I think sometimes I've been asked this question from some of my students. Well, first of all, from the literature. I think the literature is the go place to find ideas. Often in guidelines or in papers, at the conclusion, they say, well, more research is needed in this field, or they say there is a gap in knowledge in this and that. So they really spell that out quite clearly. And so you can grab the opportunity there. From your clinical activity, that's also the best way. If you don't know how to treat a patient in a particular situation and you search in the literature, the answer, there is no answers, then that's where the research need is. From formal rounds or informal meetings with colleagues, often chatting with colleagues, ideas really can develop quite easily, at least in my experience. You can also have these light bulb moments. Sometimes I have those. And you can have them anywhere and anytime. For example, for me, a source of inspiration is flying. You look outside the window, the clouds, and start thinking. And sometimes I've been finding some ideas at that moment. So never underestimate when the ideas can pop up. There is also more formal literature, how to generating ideas. And this is a very interesting book that I recommend reading if you're interested on the topic. You can find ideas by basically looking for sources of information, as I said earlier, literature, research publications, websites, on the internet, just reading about it. Or it can just arise from yourself and your brainstorming. And as part of the brainstorming exercise, you can do what is called mind map, for example, which sometimes I do myself. What is a mind map? Is essentially it's a map, it's a diagram that visualizes all the information, the tasks, the words, the concepts. Is an easy way to brainstorm, and you can be as creative as possible about it. This is not my mind map. I just downloaded one from the internet, but it shows that there is a problem at the center, like for example here, solving global warming, what to do. And there are many things, and each branch of these three is a different aspect of it. And then it can subsequently branch even further. And you see, then that encompasses the whole scope of the problem. And you can do the same with your research, brainstorming and research idea, having the topic at the center. And this is really trying to scope, where you want to concentrate. And then in your research, you will have to pick just an area. I mean, you're not going to do the whole lot in a single research project. So essentially, to get started, you need to brainstorm for ideas, look for ideas, have an idea, set the goals for your research, list key questions you want your research to answer, write down the type of data that you need to obtain to be able to answer those questions. But framing a research question sounds easy, but it's not that easy. It's one of the most important steps in planning research. And I'm sure Harriette will talk about this also when it comes to grant writing, because you gotta spell out your research idea quite clearly at that time. What is a research question? Is the question around which you want to center your research. But there are some rules about generating a research question. You gotta be clear, so provide enough information for an audience to be able to understand it without additional explanation. It has to be focused, so narrow enough that you can answer that question. And in a clear fashion, it needs to be concise. So like quite short in length, I guess, so the message becomes clear. And it needs to be complex, but in the sense that you don't require an answer that's just yes or no, but it needs to be a more articulated answer, which will justify the research. And then arguable, that's the other thing. So I give you an example of good and bad research questions and clear and unclear. For example, this is an unclear research question. How should social networking site address the harm they cause? Well, a clear research question, a similar clear question would be with a lot more details in there, my space and Facebook and protect personal information and privacy. So why the first one is unclear? Well, because it doesn't specify which social networking site, so it leaves it very vague, and it doesn't specify what kind of harm the site might be causing, and it assumes the harm is proven or accepted. Whereas this is clear because it specifies the sites, it specifies the potential harm, and also who might be experiencing the harm, the users. So a strong research question should never leave room for ambiguity or interpretation. A non-focused research question and a focused one. You see the difference. What is the effect of the environment from global warming? I mean, it's very vague, it's very broad. And whereas the focused, what is the most significant effect on glacial melting on the lives of penguins in Antarctica? So here is so broad that you can't address this on a research study. You can write a book about it, and probably is not even enough. You need to write more. Whereas this one is more specific, focused on the global warming, is on the specific place, specific animal, and also the impact that it has on the animal. So make a research question as narrow and focused as possible. And finally, when it's too simple, it should be in between being too simple and too complex. And so too simple, how doctors addressing diabetes in the US. I mean, this is very broad. And so you can look it up in Google online and you'll find the answers. And you don't need the research in this, if that's your research question. And more complex would be with all these various aspects of behavioral, genetic, and other factors. So that's where the research would be needed indeed. So if you do a quick Google search, you find already the answer to your research question, then it's likely not to be an effective research question that you've formulated. Final key consideration, so you need to understand the biology, physiology, and epidemiology of your topic of interest, identify unmet clinical need, so your research will be relevant. You also need to, well, you know the literature already because you've done your homework beforehand. You need to understand what's your role or your research. Is it incremental? Often is incremental knowledge, is not just a Nobel Prize new finding. In most cases. You also need to check that there is internal validity, so the methods are adequate, that there is feasibility, that you don't want to do something for which you don't have patients, for example, or for which is impossible in a certain time length to identify those answers. And whether also the results will be generalizable to a broader population. And so ask the right question, have a passionate interest for that question, and is there sufficient doubt about the question? You know, it needs to be valuable to do it, not something that it's already known, for example. So PICOT is the technique to write questions. So you need to include patients, intervention, comparison group, outcome, and time. And so in other words, what population you want to study, you need to specify the intervention that you want to do, the control group, if any, the outcome that you want to measure, and the time frame of your research study. And so this is an example of the question. So does a certain intervention influence a certain outcome in patients who have certain characteristics of the patient over a certain period of time? That's the sample one. And okay, I'm just gonna basically go to the final tips. Yeah, so those are recommended readings. I'll be happy to share my slides for this group at the end of the talk, but this is recommended reading, particularly this clinical epidemiology. This is from McMaster University, from Harriette's institution, and it's an amazing guidance book. And never give up, just a word of encouragement. You know, it's a hard work, this research, and never give up because you can be very close to succeed. You never know until you do it. And final tips, focus on a topic that's of genuine interest to you, have the right motivation, know the literature, start with a narrative or even better, a systematic review, but you need to learn how to do it. So go on a course, get trained, and learn how to do research properly. Thank you for your attention. And thank you for organizing.
Thank you so much, Chiara. That was really, really insightful and some great tips on how to conceptualize an idea and turn it into a research question. To introduce our next speaker, I have the absolute pleasure of introducing Dr. Harriette van Spall. She is a trailblazing heart failure clinical trialist, a wonderful person and a great mentor and a very good friend. And I would like to introduce her. She has completed her Doctor of Medicine degree and postgraduate clinical training at the University of Toronto, and subsequently earned a Master of Public Health at Harvard University. She's an Associate Professor of Medicine and a cardiologist with a clinical focus in heart failure and echocardiography at McMaster University. Dr. Van Spall is a Canadian Institutes of Health Research funded scientist who leads clinical trials in heart failure at the Population Health Research Institute. She's an adjunct scientist at ICES and has garnered more than $4 million in research funding, won several research awards, and has published her work in high-impact medical journals, including JAMA, Lancet, Circulation, JACC, the European Heart Journal, European Journal of Heart Failure, and Annals of Internal Medicine. She is an invited speaker and media correspondent, serves on the CIHR College of Reviewers, and is an editorial board member, associate editor, and peer reviewer at several high-impact journals. Really impressive CV, Harriette. Harriette will speak to us on writing for success, tips and tricks for a successful grant application. Over to you.
I am so honored to be here. Can you hear me? Hang on. Am I on mute? Oh, perfect. No. Okay.
Yeah, great.
I'm honored to be here and to learn from everyone else who's on this panel. And I'm going to jump into our topic today, which is one that I'm passionate about. It's about writing successful grant applications. Grant applications to me are a labor of love. They are academic currency. in a tough environment that could be challenging, particularly on women. They are our gateway to research freedom. They are a tangible way to impact science, to build research capacity both at our institutions and in underrepresented regions of the world. And finally, they are a pledge and a commitment to funders that we will deliver on the research projects that we outline in these grant proposals. The first step in a grant application is assessing your readiness to apply. Are you eligible for funding? So some granting agencies have specific requirements and institutional affiliations that you must meet. Do you have the experience or support to lead the research? Have you done pilot work to demonstrate that you have the leadership capability to run a bigger study for which you are applying for external funding? Does your area of research meet the grant call? And is your study question novel enough and original enough that it merits funding? Finally, do you have the access to research infrastructure? Are you either embedded in a research institute with the appropriate resources, or have you aligned yourself, affiliated yourself with another researcher who is at such an institute where you can, for example, collect data, protect personal identifiers, conduct analysis, and ensure that you have enough scientific expertise in the team? A second tip is to start early. Grant writing can take several weeks. I typically give myself about 12 weeks for a new grant. It is important to begin early and define your overall goal and break it down into specific aims. The question must be original. There's no point in rehashing what's been done before. The question should be important and relevant to the patients we serve. That's an important requirement. And it has to be clear. The first step in writing a clear grant is for you to be clear on what the research goal is and to break it down into aims that are crystal clear to you and that are linked with crystal clarity and consistency with outcome measures, methods, analytic plans, and inferences that you can then draw. You must gather the required documents. Several required documents must be garnered and gathered early on in the process. You don't want to be writing to people a week before your grant is due and asking for letters of support or asking them to provide budget justifications. Do this early. It shows respect and organization. Invite co-applicants on your grants early. Think about diversity in all its forms. Think about diverse expertise. You might need bioscientific expertise. You may need epidemiologic expertise. You may need statistical expertise. Think about diverse demographics. Give people the opportunity. Try to avoid big names who may serve as lame ducks on your grant. Think about engaging your co-applicants and drawing on their strengths. Think about giving opportunity to early career researchers. I always include an early career researcher, and I try to be gender neutral, but I think about young women in particular. I was never invited into grants until I won my first major external grant, and I try to give this opportunity because it is academic currency that we can all use to build our CVs. Think about how they might contribute either to developing your protocol, improving your writing, or implementing your research. Start writing a little bit every day. Writing is so much fun. It is your stamp on research. Try not to think about it as work. Think about it as making a mark in your field. And the biggest way you can make a mark is by applying and winning funding. About 4 weeks before the deadline, circulate your application to the entire team of co-applicants. And I always, for the past 8 or 9 years, I've always included patients as partners in research. They help me identify questions that are relevant to them that I might not think of as a physician. They also help me determine ways to answer my research question without burdening them with research responsibilities. So we design research with the goal of having as diverse a recruitment population, and to get enough women, to get enough people who, you know, represent the spectrum of socioeconomic status. You need to think about how we typically burden patients with our outcomes collections. Think about ways to make research less onerous. And I have to say that our patients taught me how to do this. 2 weeks before the deadline, you want to do final edits, polish your grant, make sure that you're nitpicky, critical, and have a perfectionist view so that it comes across as a polished piece of scientific work. Address the evaluation criteria before you start. So we evaluate grants based on the research methods. So we don't want weak methodology. You want to make sure that your research methods are robust and limited in bias. You want to have an original proposal. As I say, this is something that you need creative energy for. You need to know where the pulse of the funders is at. You need to know what are the major gaps. You know, what is it that we don't know yet that has the potential to improve outcomes that are meaningful to the healthcare system, that are meaningful to patients. You want to have a track record so that people are comfortable in funding you. Nobody wants to drop millions on somebody that has not delivered on research promises. So that's another criteria. You want to show that you are in a research environment where it's feasible to do your work and to complete your grant proposal requirements in time. And you want to make sure that you communicate with clarity what the impact of the research is going to be. So if the research that you're proposing is not going to impact some aspect of the healthcare system, then it is unlikely that you will be funded. You want to write daily. I love writing. I find that everything else is a sacrifice in some ways. I mean, I love clinical care, but I love coming back home from work and sitting down and doing a bit of writing every day. Do it with love. Do it with discipline. It does require some self-sacrifice. It is difficult to juggle our very busy clinical workloads with our research commitments and the love we have for our family. But nurture your piece of writing like a child. And I don't know how to describe this any better, but there is an element of tending to it, improving it, and making sure that it reflects who you are, your expertise as a scientist, but also the clarity that you have, your vision, your commitment. All of that has to come through in a grant application. And then if you're not inspired to write on a given day because you're too exhausted, you've worked 14 hours, you could work on tables, figures, appendices, all of the other requirements, or send off some emails so that you're getting those letters of support, but commit to your grant every day. Clarity is so important, and Chiara mentioned this. Be focused in your research question. Be specific. Break down your research question into specific aims that you are going to answer, and make sure that you're doing something that's relevant and important. Get the style right. A good grant has a different rhythm and flow than a manuscript. So review previously successful grants, ask some of your colleagues who have succeeded, and make sure you follow that format. Get down the piece of writing, then get it down perfectly. So first, you just have to put things down in writing. Don't sit there and you know, perseverate to get it perfect, but get it down. Then get it right in terms of the scientific rigor. Make sure it's methodologically sound, it's factually correct, it's supported by references, that you're not sort of making claims that aren't founded in scientific evidence. Then get it pretty. And the easiest way to get it pretty is by thinking like a surgeon. You want to cut out jargon. You want to cut out redundancies. You want to make sure that every sentence has a purpose and needs to be part of this application. So you don't want to be repeating yourself and sounding garbled or confused. Finally, get it out, making sure that you have all of the elements required from your grant. Know who your audience is. Most people reviewing grants don't have the micro focus and expertise in your area. So you want to write with clarity, but also without getting into too many weeds and too many details that are going to kill your grant. Give the big picture. Why is the study needed? What will it add to science? And don't drown your reader with complexities. I have to say, despite being a diligent and patient reviewer, I know in the first paragraph or two whether this grant is going to die or whether I'm going to shortlist it. You want to write clearly, you want to use subheadings, try to number your subheadings, try to ensure that the flow is accurate so that it takes the reader through the storyline of your grant application and doesn't fatigue them out where they just want to throw your grant and walk away. Use scientific writing structured in a way that's not narrative. You're not writing a piece of poetry or prose. You want a great lead sentence to every paragraph. It has to come across, boom. The person reading it has to know what that paragraph is going to be about, and your first sentence, without looking at the rest of that paragraph, needs to communicate to the reader what that paragraph is going to be. So it has to be strong, general enough to capture the rest of the paragraph, but also focused. And then you want the rest of the paragraph to have supporting sentences that are armed with evidence as much as possible. When you're editing, you want to take out any repetition and rambling, as I call it. Ensure internal concordance. I will say I've reviewed more than 1,000 grants at this point. The biggest flaw that scientists have is that their study aims are not linked to outcome measures and are not linked to an analytic plan. So they start listing aims in the introduction, and then somewhere along the methods, there is this snowballing effect, and you see all kinds of other analyses creep in, and you think, what does this have to do with the study aims? And what research question is this analysis actually going to answer? Sometimes there's complete discordance, and then the grant's dead. Use illustrations, figures, text boxes to improve the readability. Right in the first sentence, we don't want professorial third-person writing, participants will be recruited. You want to make it lively, active, personal, as much as it is scientific. And then be careful about terminology. You don't want to conflate cause effect with association. So if you're doing an observational study, don't say that the impact is going to be that you will assess the effect of variable X on outcome Y. You want to make sure that your inferences are appropriate to the type of study methodology. Another common source of error is confusing sex with gender, race with ethnicity, and these aspects are important at many federal level granting opportunities. You want to make sure that you recruit enough females and males, you want to recruit diverse populations, and you want to use the right terminology so that you come across as somebody who knows what you're actually talking about. Follow the formatting requirements. These are the formatting requirements for our federal grants. The first is a one-page research proposal. This sells the importance. You want to build excitement. You want people to just long for what's coming next. So you want to do this towards the end. The second is a research proposal, which comprises a background. The background I always write last, and it's a good tip because you want to do the background specific to your research plan. So you want to start off laying the research plan, study aims, methodologies, and then using the background to bring it to life. The third component is the timelines, and I recommend using a Gantt chart so that the funders know when you're going to deliver on specific aspects of your grant. And then the final one is the research significance, which is a small component, but which should make it clear to the reader what the implications and anticipated outputs of your grant is. Another component is the budget. You want to justify your budget. You want to be accurate, and you want to make sure that you list personnel that are tied to the aims of the project. So you don't want to just list personnel where it's not clear to the team what their role is going to be in helping you answer the question. It's great to list specific people. Think about building research capacity always. You need to budget for your PhD students, master's students, postdocs. And if you have those people identified, list their names, because then it sort of makes it personal to the reviewer, and it also demonstrates that you already have people lined up. You're not going to post a job posting, months after the grant funding is received. Keep the budget reasonable. You don't want to be cheap in your grant request, but you don't want to be inflating costs either. Before submitting your grant, check the checklist of requirements, check for clarity, check for typographical errors. If you can't put a grant application together with clarity and an eye for detail, a reviewer will look at you and think, how are you going to actually run a clinical trial? If you don't have the eye for detail, you know, in a 5-page document with, you know, 50 pages of supporting documents, you know, how are you going to execute a multi-center trial, right? So take a break, check again, take a day off and go back and look at it with a fresh set of eyes. And, you know, we do this work like we do our manuscripts in layers, and there's constant improvement between cycles. It's not a one-shot job. If you don't get funded, don't get discouraged. Incorporate feedback. Rejections and feedback are our greatest gift to improve our work. Rejection is a blessing. It stings, but it gives you the opportunity to look at your grant, to look at your manuscript again with a fresh set of eyes, to incorporate free feedback. So all of us review grants for free. We're donating our time and we're lending our expertise to help you improve your work. So on the other side, I look at feedback as a gift, and it just recharges me and makes me go back to the drawing board and you know, completely committed to winning the grant the next time around. In the interim, look for smaller funding opportunities. You don't want to go for a big federal level grant without pilot funding, without pilot data, without being able to demonstrate that you can make good headway into answering the research question without, you know, those millions of dollars of funding that you're now requesting. And I'll take your questions at the end. Thank you for the opportunity, and I'll give it back to Aaysha.
Thanks, Harriette. That was really, really insightful and fabulous. I learned a lot of things, and I'm sure the rest of the audience has as well. To introduce our next speaker, I will hand it over to Tugbe.
Thank you so much, Dr. Harriette Spall, for great presentation and so useful tricks. I would like to introduce our third speaker, Dr. Elissa Altin. She is an assistant professor at Yale University, a graduate of Harvard College and Harvard Medical School. She completed internal medicine training at Yale and cardiology, interventional cardiology, and endovascular interventional fellowship at Columbia University. Her clinical specialties include coronary and endovascular intervention, with a particular interest in management and treatment of chronic limb ischemia, invasive hemodynamic assessment in women. She serves as the Director of Clinical Research in Interventional Cardiology and is committed to applying novel technologies in the care of patients. We are watching you, Dr. Elissa Altin.
Thank you all so much for the invitation to join this group. I have already.
Can you hear me?
I can. Can you hear me here? Can you hear me?
Yes, Elissa,
okay.
We can.
Okay, great. So it's such a pleasure to be with you all today.
Yes, but there is little. Okay.
Better?
It's freeze.
Yes, Tugbe, I think we can hear Elissa. Yeah.
Okay, I can hear you.
Okay, great. So thank you for the invitation to come join you. I've already learned so much from the first two speakers, and I think that the success of being able to run a clinical trial well has absolutely everything to do with one, asking the right question, and building out the proposal in such a way so that once it gets on the ground, some of these issues that I'm going to discuss will be easier. I have no conflicts of interest relevant to this. So when I think about a clinical trial, I think about what are the ingredients that we need to make it work. One, you have to have some passion for the question, which Chiara addressed. And the person initiating the trial should have the passion, but the people running the trial also need to share that passion. And that needs to be essentially an infectious passion that is transmitted to the group so that everybody feels like they're part of it. You need the right team comprised of the right team members, and we'll go through some of the ingredients of that. And what I think is really important is some sort of team ownership of running of the trial. so that the successes are the successes of everyone, not the PI, not the sponsor, but of every person on the team. And that if there are problems and limitations, that it becomes the team's issue to fix those. So first, when starting any trial, there's going to be a lot of roadblocks and a lot of red tape. So there need to be team members that are well-versed in dealing with sponsors in IRB documentation, regulatory issues, and budgetary issues. These can be so overwhelming that it can diminish the overall passion for the question and the overall passion for the project. So having networks in place to deal with this early with people that are competent and experienced makes the rest of the process much easier. And the stages of running a clinical trial are similar to the stages of anything that we do, but first is the initiation, which we already talked some about. Then is the execution. Important is the monitoring and the controlling of the study. And finally, the analysis and reporting that we'll talk about in the next talk. So first is initiating, which the first two speakers have discussed. So forming the question, assessing the feasibility, having a statistical plan, determining the resource allocation of who does what, and identifying a time frame that is feasible, so that when you take it to the site is fully on board with exactly what needs to happen, what they need to do, how long it will take, and what the expectations are for enrollment. From the project team needs to include PIs, a trial manager, statisticians, programmers if necessary, and a data manager. So when we think about executing, enrollment is the key. So how do we increase enrollment? So first, you can raise the profile of the study, have presentations to members of the team, presentations to other providers in the area, engage the community. But the enrollers are really the first line. So we need to empower and elevate the enrollers, the people going to the patient bedside, the people explaining the study, the people consenting for them are the face of the study. When you write that question, when you review the literature, you don't realize that there's going to be a person who has to then reinterpret that question in a way that makes sense to a patient, that they feel that they are helping not only themselves, but also the greater improvement of science to enroll in this, because people get scared. You tell them, you know, there's this possible study we could enroll you in. And the first experience is, I don't want to be a guinea pig. You know, I don't want you to try something on me that we're not sure works. So the enrollers and the consenters are the first line of the experience of patients at the interface of the study to the actual enrollment. The other thing that's important is that both investigators and the participants or the patients should face very minimal burden. The second it becomes really hard to do the steps necessary to keep a patient enrolled in the study, you will lose investigator input. They will not be able to keep patients in the study if they don't have the clinical workflow to do all the follow-ups. If you're doing an interventional study and it has a lot of steps and is a bit unwieldy and adds time to the day, that can be a real barrier. And then patients and participants following enrollment should not be overburdened by the requirements of study participation. And of course, monetary incentives help. And that helps on both sides, both at the institutional level and at the patient level. And when thinking about the team at the institutional level, in as much as it is possible, we like to just realize that we're all working together. So it's not the PI, it's not the sponsor, it is everybody on the team who benefits from the study doing well. And so any abstracts that come out of the study, any publications that come out of the study belong to the team, and all members at all stages should be included in these successes, such that this rising tide will lift all the ships. And as people get more excited and interested, they'll be more willing to do the hard work. As far as monitoring and controlling, this relates to making sure that the study is first safe, and then that periodically you're checking in to see what's happening with these patients. So there needs to be standardized data collection forms, case report forms, and someone to oversee the data entry to make sure that it's all appropriate and correctly done. Often the person doing the data entry does not necessarily have the skill set to understand fully what the data may mean. So making sure that you have someone going over it to assess that it's put in correctly is quite important. You need to have a plan for intermittent data evaluation for safety, and also just to see where you're going and whether or not the question is going to be able to be answered, if it'll go in the direction you think, or if it's going in the other direction. And a mechanism for engaging the patients in follow-up, either phone call or in person, and what subsequent studies you need for the outcomes. And as far as analysis and reporting, intermittent safety assessments are important for participant safety and to evaluate the study conduct and progress. And if necessary, you may need to modify or terminate the trial around these safety assessments. And I think additionally, periodic assessments of enrollment are important, because you'll find that there will be times when enrollment slumps. And when enrollment slumps, it's important to get the team together and figure out why exactly enrollment has slumped. Is it something about the team? Is it something about the study? Is it something about the time of year? Is it around the holidays? And to sort of see what are the issues that can be helped to continue to improve enrollment. So the reality is that 85% of clinical trials don't reach their recruitment targets within specific time periods. And almost 20% of trials are closed or terminated early due to not accruing enough patients. And only 6% of trials are completed on time. And this is all from the FDA. So it is really important that at the ground level, you have to really make sure that the enrollers are able to enroll, that you're finding the patients, that it's appropriate study for the institution, that it's appropriate study for your patients. Otherwise, it'll suffer. And the other thing that is extraordinarily important is that the study and the question reflect the population that we serve. So if the study does not pre-specify diversity, the study may not have diversity. So we need to make sure that at every stage, we're thinking about how we can reach the maximum number of patients and improve the care of the maximum number of patients. So at the study level, at the question level, it is important to make sure that we're asking to involve the most patients possible as far as different races, ethnicities, and gender. But then at the site level, we need to ensure that the site can support that level of diversity. So if you're asking a question in one particular population, that site needs to have that population to support the question. Some factors that are known to increase recruitment: having clinicians that are interested in evidence-based practice. So that's actually really important. It sounds quite logical, but it gets back to Chiara's point about enthusiasm and a passion for research. So if the clinicians are not interested in research, they may not have the passion for the enrollment. Clinicians that participate in an academic group tend to have better recruitment. Sites that have extra staff that can help in recruitment do better. And having clinicians at the sites that feel comfortable explaining the trial is key. So that gets back to this idea that you need to have a strong clinical question that can be simply expressed essentially in one sentence. so that can be transmitted to the clinician on the ground who is asking the patient, do you mind being enrolled in this study? Factors that impair enrollment are important. So competition between studies is a big problem. When you're thinking about which studies to bring to your site, try really hard not to have studies that are going to compete against each other for the same patient population. There are times when those studies can align and you can actually dual enroll in two studies so they don't compete, but try very hard to not have two competing studies, because it only limits both of the studies from their ability to meet the enrollment goals. Tension between clinical and research teams around workflow is a big problem that can impair enrollment. So the clinical team wants to do good work for the patient in an efficient way, and the research teams want to do good work for the patient regarding enrolling them in research. If there is a disconnect between the workflows in that, people will not get enrolled in your study. So identifying if there are those tensions and how they can be relieved will improve the ability to enroll. And then it's important to assess what are the staff perceptions of imbalance of patient burden versus benefit. Sometimes you'll have the consenter or the enroller talk to the patient. The patient will then talk to their care provider, their nurse, their other staff member, and say, hey, what do you think about this? So it's important that when we approach patients with studies that the staff knows that we're going to approach them with a study and explain it to the staff as well, so that they can help the patient sort of discuss it without being concerned about any potential burden to the patient. And the other thing is who's doing the consent. Some people are better at consenting than others. So it is important to take aside members of the team who are going to be doing the consent. Watch them do a consent or two. Do a consent together. Make sure that the consent is truly informed and fair, and that it allows the patient the full freedom to agree or decline, but that it is ultimately a positive experience for both the consenter and the patient. And then finally, another issue that can impair enrollment are patient-level concerns around research and engaging in research studies. And this can ultimately affect the diversity of the trial. So that becomes quite important to engage with maybe potentially some community-based programs around trying to enroll patients, maybe not always enrolling them at the time of the hospital, maybe trying to get them engaged at the level of a community action organization, explaining the study, why it's important in a population outside of the hospital where they potentially feel more comfortable with the people that are presenting it to them. So there's a lot of barriers to getting a study up and running and to high enrollment. But ultimately, they're able to be navigated as long as you keep in mind the potential pitfalls. It's really been a pleasure to discuss this on the ground cookbook for how to enroll. Thank you so much.
Thank you so much, Elissa. That was just a brilliant overview of the practical and realistic aspects of actually running a clinical trial. So thank you for your insight. And for the final talk in today's fabulous lineup of women clinical trialists, we have Dr. Rasha Al-Lami, who will speak on the last lap, trial data, results, and presentation. Dr. Rasha Al-Lami, quite honestly, needs no introduction, but I will introduce her. She is an interventional cardiology consultant at Imperial College Healthcare NHS Trust and a clinical senior lecturer at the National Heart and Lung Institute within Imperial College London. She is a clinical trialist with expertise in stable coronary artery disease, coronary intervention, invasive physiology, and invasive intravascular imaging. She leads a research group with a focus on clinical trials that impact the care of patients with cardiovascular disease and believes in rigorous testing of clinical practice and the use of evidence-based medicine in all aspects of medical care. Dr. Al-Lami has designed, conducted, and led the Orbiter trial, which was the first randomized placebo-controlled trial of coronary angioplasty. Orbiter, as we all know, is one of the most widely cited clinical trials in cardiology of the decade. And she's the lead author of the primary publication in The Lancet, as well as 2 secondary analyses, both published in Circulation. Aaysha is the NIHR CRN Northwest London Cardiovascular Specialty Lead and is actively involved in the development and recruitment for a number of multi-center international clinical trials. Over to you, Aaysha. Blow us away.
Thank you. Firstly, I'd like to say thanks so much for the invitation and also for including my name amongst a panel of the powerhouses of academic cardiology. So Chiara, Harriette, Elissa, it's a pleasure to be included with you. I actually was taking photos of many of your slides and trying to work out how I can make my grants successful or improve some of our trial design. So I'm going to be talking about the last lap, you know, what you do with your trial data, how you interpret your results and how you present them. And I've chosen to do this also with some examples of obviously what happened during my own research. And so firstly, let's discuss how a clinical trialist plans a trial. So we think immediately of obviously the clinical idea, we think about, we get the funding, we have this plan to do the trial, and then we just immediately start recruiting patients. We're recording the data as we go. We of course get to a point where we have the data and then we need to clean it because there's always inaccuracies in the data. And you heard from Elissa exactly how we need to monitor it and make sure it's as clean as possible. And then we get to the point where we're analyzing the clinical data. Often it's not us that do that because it needs to be a blinded analysis in most of our trials. And then we as the clinical trialists start reporting on the results. The reality is that if a statistician plans a trial, they just plan it very differently. And actually, maybe that's part of what we should be thinking about as we, as clinical trialists, start to think about our academic work. They actually go backwards. So they think, first of all, about the clinical study report and what kind of outcomes we need in that report. They then identify already what kind of analysis they would need to do. They specify what data requirements there are, and then they consider design options and determine the sample size. And actually, more and more, I've realized that that backwards approach to things means that you are probably likely then to end up with a clinical trial that really informs the clinical question more than diving in and just developing the question and starting the trial as soon as possible. So let's think about analyzing the data. Well, analyzing the data, as I said, is often a process that's actually done by others in order to really maintain integrity in trial management. So of course, we pre-specify the outcomes as an academic group, and this is always done as a team. We decide what we would like to assess, and importantly, we pre-specify those outcomes. The thing that I think we need to avoid, and it's certainly something that I was probably more inclined to do earlier on, you know, many years ago before I did my PhD, is to start fishing through data. You get your data and you start to look for a p-value that's significant. And that's really the wrong way to look at research. You should pre-specify your outcomes and you should pre-specify your hypotheses. You should also pre-specify your statistical analysis plan. And it's actually very important to try and publish that statistical analysis plan, or at least have it somewhere documented so it doesn't change again. And we've seen lots of trials that have been criticized for statistical analysis plans that have changed at the point at which the trial's already recruiting, or even worse, after the trial results are in. And of course, that has an element of bias, and so it's important to have that plan at the outset. We also need to think about how we will report our outcomes, where we aim to report them really early on. And of course, that might really determine exactly how we design our trial. And then, of course, we're going to get to a point where we get data output from our case report form. And for most, I think there are no clinical trials now that probably are run without electronic case report forms. And at this point, it's really important that the data is taken out by someone who doesn't have a vested interest in the results of that trial. So it's not you as the primary investigator or a project manager of the trial, it is a statistical team. And then they begin on the process of data cleaning. And of course, once the data is cleaned, the data must be locked. And it's important that that data doesn't change again. We don't then analyze the data and go back and fiddle some things or lose some patients along the way. And of course, the statistical analysis for most clinical trials is done by professionals, but most importantly, by blinded investigators, or as I said, people who haven't been part of the trial recruitment, who aren't part of presenting the results. I think that is really important to maintain the independence of statistical analysis from the PI. And then it's us as the PIs who sit there and interpret those results. And that's a process that I think is different for different people. But again, it's really important when you're doing the result interpretation to remember what your pre-specified outcomes were. And if the results aren't what you want, well, that's the world we live in and the data that you have to now present. So some top tips for data analysis. So I think you have to apply a deadline to this. I mean, you need to think to yourself, how long is this going to take and when's it going to be done? Sometimes that's natural because you will put in your mind a late breaking clinical trial presentation you want to do, or a particular moment where you think it's reasonable that this data gets presented, but apply a deadline, because this can obviously take as long as the statisticians want it to take sometimes. And importantly, it allows sufficient time. The wrong thing to do in data analysis is to rush it, because of course then we make mistakes. Important, don't manipulate the results. I know that sounds like an obvious thing to say, but certainly we've all seen, projects where data points have been lost, or, things have been changed. Most of the time I try and very much land on the side of, it was an error and it was never deliberate, but, you do have to be careful. People will one day come back and look at your results, and you should be prepared to show your results in their entirety if needed and stand by them. Maintain high standards. So of course that's important. You are going to be, you are going to live or die by your results and by the standards of your results. And if there are results that people don't like, you have to be able to present those results knowing that there isn't a single bit of doubt in your mind about any of those results that are there. Present the results in an understandable way. I think this is a point where sometimes people trip up. I think it's important to be able to read a paper on a tube or at the dining table, or quickly, you should be able to read a paper in a pretty short space of time and understand what it's about. So therefore, the results need to be understandable. And for me, I usually look at the results first. And if the results are very hard to interpret, that always makes it difficult to work out what that trial's about, and certainly reduces the impact of the trial. Think about clinical interpretation. You heard that many times in the talks today. Ultimately, if what you're doing is not clinically relevant, it will not have the impact. It may do what you need it to do, so get you a paper on your CV, but if you want to become an academic, you'll want to have impact. So in terms of the interpretation of the results, I'd say be prepared for surprises, and I've definitely learned that, and I'd have told myself that many years ago if I was going to go back again. Think about the clinical implications, think about what your results mean for the wider population. Be objective. I think it's really easy for all of us to try and overstate the value of our results. And that's because we believe in them and we become invested in them, but we have to be objective. Try not to overinterpret. That's part of the same thing. Don't, as we heard earlier, don't make something causative when it can only be an association. Try and work out exactly what your results show. Consider the limitations, and I've definitely had to do that over the years. Think about where your research answers a question and where it doesn't, and what you need to do next. And ultimately, that often becomes the next thing you do. Think of the wider picture and what the implications of your results will be, not just clinically, but also on a much wider landscape. Involve others. So don't interpret the results in a little siloed room on your own. Involve others so that they also think about your results. And here I really do involve patients, because they're really invested in the results often. And don't rush. The interpretation takes time. You need to get your head around it, especially if you're surprised by the results. Consider the impact of your work. So, we can all work in these research bubbles where we're sitting there with our own work. We're really happy with how our CV is progressing. But ultimately, beyond academia, if you burst that bubble, there are lots and lots of different ways in which what we can do has impact. And so as you're designing your trial, think about it, but importantly, in that last lap that I've been asked to talk about, think about the impact of your work and think about how you create impact. So at the beginning, you obviously have to have a decent vision. You have to build some decent relationships, because those people are your team. You have to plan effectively, and then you really need to think about impact in how you disseminate your outcomes. And then it's really important to gather feedback. And over the years after each clinical trial, you start to learn what you'd have done differently, and you start to be objective about your own work. Now, the presentation of the results is also incredibly important. I usually try and prepare a publication with a journal in mind. That may or may not be the right approach, but usually there is a particular writing style or something that a particular journal will want. make the paper readable and interesting. As I said, it shouldn't be that people have to then Google multiple acronyms or go off into searching about your statistical techniques. They should be able to understand what you do. Sometimes you'll use statistical methodology that won't necessarily be intuitive to the reader, and that's okay, and that's part of science. But then at least in the discussion, you need to be able to explain to them what it all means. Aim appropriately high. I think that's fair to say. We all want to aim at the very top, and then there's this cycle of like bouncing down the ledges of a staircase. Actually, I think you should just aim at an appropriate level at the beginning, but higher maybe than where you might end up, and then be prepared to go down. I tell my fellows try not to present abstracts without publication acceptance. I have learned very much over the years that actually what's important about research is the publication, and that's what stays in the annals of history. And actually abstracts are fantastic because in the olden days, they got us all over the world and we met colleagues. And of course, when you're an early career researcher, you really want those opportunities. So I think abstracts are fantastic, but try not to have the abstract as the main aim. The main aim should be the publication, and the abstract is a bonus. And the abstract and the conference you choose should be based around the fact that you're nearing publication somewhere, particularly because if you present your abstract and release your data, it becomes sometimes harder to publish. Prepare for rejection, and we've heard that from grants, and it's certainly the truth for publications, and allow time for revisions. And that's, again, really important, particularly if you're presenting it somewhere coming up soon. You need to be ready for the time for the revisions. And be prepared to defend your results. And that's something I've definitely had to do. And of course, part of that is being comfortable with the data that you've collected. So very quickly, I'm going to run through my experience of the final lap process, just to give it some kind of personal touch. So as many of you know, coronary angioplasty was really the sort of cornerstone of interventional cardiology, and this paper in 1978 describing coronary angioplasty for stable coronary artery disease was the pinnacle of what many of us do. As a result, angioplasty has really evolved, and it's a booming industry that's evolved over many years. But of course, predominantly it's for patients with acute coronary syndrome, where we know that the evidence is incredibly clear that coronary angioplasty is important. Where it's not so clear, we felt, was when you had a very tight stenosis like this on this angiogram with stable angina, and we asked the question, why do we stent? And so we also felt that maybe while there have been lots and lots of seminal papers on the subject, that what they'd missed out on was that placebo is a very important part of medical care. And we all know that red pills deliver more placebo than white pills, that big pills actually deliver much more placebo than small pills. And I know from my relatives that they much prefer an injection for an analgesia than a pill, because they're sure that that works much better. And importantly, that surgical procedures deliver the most placebo of all. We also know that subjective endpoints really do require testing with placebo controlled. So whether that's quality of life, blood pressure, weight, chest pain, all of these endpoints have an element of a placebo within the clinical effect that we see. So we started recruitment for Orbiter in December 2013, and we had that hypothesis, the pre-specified hypothesis. And later a lot of people said to me, why was that your hypothesis? And I had to say, well, it was the hypothesis that we thought was reasonable at the time. And we felt that coronary angioplasty would increase exercise time more than a placebo procedure. We then worked incredibly hard at 5 UK sites, and you can see lots of the investigators there. And this really speaks to what people have said today about how important it is to have a team. This is not you on your own running a clinical trial. This is you as a group making this thing a success. And as part of that team, there are a whole load of patients, and our Orbiter patients were fantastic because they actually took part in a trial. And you heard from Elissa, this is the kind of trial that actually it's hard to consent for very, very quickly. You need to get patients on board with the potential of having a placebo procedure with added risk and not having any benefit. And here are a bunch of our patients, and they're a really integral part of our team. So finally, we recruited our last patient in July 2017, and the reality, and this is where it comes to the talk, the final lap was where the hard work really, really began. And this is the bit that I guess I felt that I had never known before, and I learned on the job. And so I'm giving you this experience so that hopefully you won't have to. So all of a sudden, as I'm very excited about presenting some results, I'm worried about those results as an interventional cardiologist. And obviously I know results that no one else knows that are embargoed. And I'm a bit conscious of the fact that this will not necessarily be received well, all of a sudden people start writing about it. And that's, I guess, what shocked me. I didn't really understand the impact of what we were about to do. So all of a sudden, journalists start saying, what if PCI is just a sham? And really important interventional cardiologists who I really respect suddenly start saying this is the first sham control trial of PCI and the sharks are in the water. And that's part of the final lap for me. And on the 40th anniversary of the very first Lancet publication, the one that I just showed you of angioplasty, we had our own Lancet publication and we were on the front page. And unfortunately, that front page said something that was pretty controversial. It said, in patients with medically treated angina and severe coronary stenosis, PCI does not increase exercise time more than a placebo procedure. Well, I'm an interventional cardiologist, and that's definitely not the front page that I foresaw as a budding clinical, as a fellow many years ago. But these were the results, and this is what we had to stand by. So now it comes to what happens when you present. Well, all of a sudden you're plunged into a kind of limelight, and I certainly was. And that limelight is pretty intimidating, actually, particularly then, very male orientated and very scary. And you're having to defend yourself against people who you actually really respect and for many years have looked up to and have referenced in every paper you can think of. And now you're amongst them. And more importantly, not only are you amongst them, but for me, it was that many of these people did not like what I'd done. And they worried that I was a little upstart that had come to kind of upset the apple cart. So what happens when your research has impact, but is controversial? Well, what happens, unfortunately, is you end up with editorials like this that says, this is the last nail in the coffin for PCI. And this really comes down to that, don't overstate your results. This was never a statement I made or any of the investigators in Orbiter made, but it was a statement I had to defend. And increasingly, I started to say, I cannot defend an opinion I don't hold. And an editorial that's written by someone else is their own opinion. And so all of a sudden, again, unexpectedly to me, we were in the media. And I'm sure many of the ladies today will talk to you about what it's like to present your result on a kind of international stage and how tricky that is as a medical professional. And when you're starting to talk to journalists, it's incredibly difficult, especially when you haven't had media training, because any slip up can be a real mistake. And I still remember various moments where I kept being asked, which stents did you put in an orbiter? Which stents, which manufacturer? And I kept saying, it's not important. It wasn't part of the trial. And thank God I said that, because it turns out that had I said one company or another company in particular, we'd have gotten a lot of trouble because the share prices of multiple stent companies dropped as a result of orbiter in any case. They've all recovered, so no one needs to panic. But it was really important that I kept to the results and I never overstated what we'd found. Then I guess the other aspect of this, and this is the environment we live in now, and I think really started around the time of Orbiter, I think it was one of the first trials that really hit on this, was Twitter and social media. And what happens when your trial is suddenly being interpreted all the work around the world by academics, interventional cardiologists, patients, trolls and bots and all sorts of other things? That gets really intense as an academic. It's also, you know, the medical media start to talk about you. And again, that's very hard to deal with. Various institutions that, again, you respect. So here's the Society of Cardiovascular Angiography and Interventions making their own statement about Orbiter. And again, these are societies that I respect. And so, of course, it's always tricky to try and work out where you sit in the landscape if people are upset with what you've done. So since then, we've had lots and lots of editorials written about Orbiter, and they don't really stop. And that's part of the final lap. But I guess the reason I showed all of this was also to tell you do have to defend your results. And therefore, you must be happy that you didn't make a mistake and there wasn't some patients that were lost or some data that was somehow incorrect. Because afterwards, I had to write many statements in defense of what we'd done. And you can't write those statements if you're a bit worried about what you've done. So finally, and I'm nearly at the end, what are the real lessons about that final lap? Firstly, I think one lesson is it's very difficult to make a man understand something when his salary depends on not understanding it. So be prepared if you are designing quite controversial stuff that may well impact on having financial implications. There will be people out there that will criticize what you do if you don't say what they like to hear. But also, incredibly importantly, and this, I guess, is the real legacy of what I did and what we're all facing now, is that Milton Packer said this, and it kind of, was really emotional for me reading this. He said, the legacy of Orbiter is if an investigator presents the results of unpopular research at a scientific meeting, he or she, I think he put that in for me, should be prepared to fight an all-out war on social media or digital news sites for a long period of time. They don't teach you that in medical school. And that's really the learning I have for the final lap. And finally, I think what's really important for all of you guys as you look at other people's research and also as you look at your own is not to fall into this trap. So this is the trap which we all fall into sometimes, which is that we see a new study released, we decide whether results validate our conceived beliefs. If they do, we say, brilliant, that's a good study and I'm an absolute genius. If they don't, we say, well, it must be a terrible study. I'm going to go off and find some flaws. Every study has flaws and they all have varying levels of flaws, but they've all got flaws. And then you find some flaws and say, yes, it's a terrible study. Right, I was right all along, I'm a genius. We need to be more open-minded about that and be prepared to have our views challenged. And my final image is also the reality of a final lap. You do that final lap, just many of us not on our own, with our friends, our family, our husband, and this is my husband in this case, my son. There are lots of people around you that are part of that final lap. And this was a day many years ago, actually, when I was at the European CMR conference presenting about Orbiter. And after we'd done the presentation, I went off around Barcelona, it was a brilliant day, on bikes. And somewhere during the day, we suddenly realized that my husband and son, who were on a tandem bike, were on a bike called Orbiter. And so this is the reality of academic research. Your family become incredibly invested in what you do, and they know the name of what you do. They understand the intricacies of what you do. And you can see here my husband cheering. He's like the general cardiologist who's very happy with the results. And my son is the interventional cardiologist who's just so upset with the results and also very embarrassed by his mother. So I'll stop there.
Thank you. Thank you for your amazing speech, and we gained deep points of how to carry out research. As a young cardiologist from Azerbaijan, I can say that your presentations will direct me in this way. Thank you, and you are really legends, and we are thankful to you. There is a question I would like to ask from our attenders. How to choose the right meeting to present and give visibility to your results? Can that help in getting them published?
So I'll just chip in that investigators submit abstracts for presentations at the late breaking or hotline trials. And it's often a matter of how significant your trial and findings are. It's a competitive peer-reviewed process. And then the trial gets selected and allotted to an appropriate session. So it's not just the meeting, it's also the session that you present at. And at the end of the day, you want to ask the right question, execute your trial with rigor, report your results with integrity, and everything else, including the session, the meeting, the media interviews, the publications are secondary, and they come. So my first trial, I presented at the late breaking session at the ESC, which is our biggest meeting. I merely submitted the abstract and then I got invited. And then the journals invite you to have simultaneous publications. And if your manuscript is ready, you can submit for the simultaneous publication. In my case, I hadn't yet completed the manuscript because the results had just been discerned. And so I presented and then it got published in JAMA, a few months later. But I appreciated the time that I had to really think about the results and make sure the analysis was correct and to make sure that what I put to paper was a good reflection of the trial, the analysis. It took into account any limitations. Sometimes when you do a simultaneous publication, you don't have that luxury of time and it's rushed, but there are many ways to do it. I would say that all of the, glory comes after. I think the main thing is to really love what you do it well, and execute it according to what you say you'll do. I don't know, Rasha, do you have any other
Yeah, no, I mean, everyone has different approaches. I guess with my work, I've usually tried to make sure that it's already in a publication process or is basically going to be simultaneously published. And I suppose that's most important when what you are presenting might be controversial. And we all know that there are times when people present results and then that data never gets published, maybe at the level that it should have been published, because the world tears it apart and influences the review process. So, I mean, I think there are many ways to do this, and you know, but I totally agree. I think you don't think about the impact, you know, the wider, what happens next and where's everyone going to see it and who's going to be in the room. I mean, I never think about that stuff. I just think about my work, and then the rest does or doesn't happen.
I love your point though about abstracts not being submitted, you know, especially lower level abstracts. With clinical trials, at least, there's a novelty to it. Nobody else can publish what you're going to publish. I find with other, you know, sub-studies or, you know, great research, but that may be at the level of a fellow or a student, submitting an abstract puts it out there, and depending on the research methodology, you know, you'll see other people potentially do the same thing. And a colleague and collaborator of mine, when we had this experience, told me, you know, because I'm very eager to send my students to go publish on these world stages, and they're so happy. It makes me happy. But I learned from the experience, you know, no, write the paper first. Yeah. Get it ready for submission, then go present.
I totally agree. And the other thing, I mean, I was once told that if you do want to become an academic, something that people really look at is the conversion rate between your abstracts and your publications. And that should really be 1 for 1. And if it's not 1 for 1, it's you know, and it's certainly bad if you've got 10 abstracts for every paper.
As an academic, I would say that abstracts have no merit. In my institution as a researcher, it's something you do for your students so that they have a chance to present. But at the scientist level, there's no upside to it really. I don't even list them on a CV. They count for nothing.
No, they're all about the travel to somewhere nice and meeting lots of colleagues.
Going out to parties.
Yeah.
Are there any other questions here? Any wise words on how to cope with the aggression you dealt with for Orbita, Rasha?
Oh, I don't know.
I think you gave us a good highlight, but how did you?
No, I mean, I think one thing I've learned over the years, and you said it actually in your talk, and I think Chiara might have said it, you have to not take things personally, maybe. And there was certainly a point at which I was taking every objection personally. But I guess that's the most important thing. You have to stand outside of it sometimes and just allow people to fight.
Yeah, and you know, the data speaks for itself. And so, you know, this brings us back to your point that you want to make sure that your outcomes are pre-specified, the analysis was accurately done, the inferences are appropriate, and then there's less responsibility on your shoulders because you're not doctoring anything. The data speaks for itself. Yes.
Thank you to all the panelists for a great session. We do have a few interesting questions. And I think one question that I had personally before I jump into these questions would be regarding retractions. What it seems to be a recent problem, especially with the literature that is coming out during the COVID era. So people want to accelerate scientific publications, but obviously you have to be cautious about how you do it. So how do you circumvent falling into the trap? Any suggestions?
Chiara, do you want to take this?
Yeah, well, I guess it's the general principle of doing things properly, you know, following the steps that we discussed here today. And yes, it's attractive to be the first, but I think we should not compromise quality. And we're seeing some of those results. So I've been personally involved on some COVID research, but it went via a grant, and we're recruiting. And so, you know, it's perceived as more delayed, but I think the results then will pay off, and it will be a stronger contribution that we're going to make.
Thank you for the response.
I would also add to that as a principal investigator of a trial or as a supervisor of a student project or a fellow project, you need to get your hands in every aspect of the research. So you don't want to micromanage, but you want to be able to confirm data integrity always. And for me, even if it's just a systematic review or meta-analysis by a bachelor's students, I actually audit the extraction, and I've caught errors that way. If there are errors, we meet, we go through every row of data, and it can be exhausting, but you never want to put your name to a paper without knowing that the data is solid and that you could stand by your work. And of course, there's little things that may be missed at the time, but you got to go back at every stage and make sure that you're able to ensure that the data was accurate and that there's integrity in the whole process.
Yeah, and there is a question here from Sara Moscatelli. Says, as a fellow that wants to start with research, should we be scared? How do we go about? And I think the trick is to find a good supervisor to start. I mean, I don't think there is expectation that, we're born with knowledge. And so you need to have a good supervisor. You need to, go courses that your university will offer, do online training. There is also courses out there, how to do research, biostatistics, epidemiology and things like that. And you need to have a good mentor and that will check, exactly what Harriette said. You're not going to be a solo player. I mean, this is labor of love, but it's a labor of team. So never work in isolation.
I would also add to that if you love research, first of all, don't do it if you don't love it, because it is an undertaking if you want to run prospective research that involves patients. And every day should be joyful, right? And not burdensome. So research can be burdensome if you don't love it. But I would say that, beyond that, you need to make sure that there is integrity in the process, that you are able to vouch for what's been done, and that you invest in it properly. So an online course or a little brief on statistical analysis doesn't cut it. You need to invest in a proper research degree, because if you don't understand the methodology and you cannot inform your statistical analytic plan, then you are less likely to be able to vouch for what comes out of the research. And I would say anything valuable in life requires investment, right? We wouldn't be practicing cardiologists without proper fellowships. And I would say the same for a primary research track career. Invest in a degree and it'll be worth it, on multiple levels. Statisticians make mistakes all the time, and you would not be able to catch it unless you understood research methodology.
Yeah, well said.
Thank you both for the answer. Thank you very much. It was a question that I had in my heart. Being scary to start and not know what to do. Thank you very much.
Another great question we have is, what if your results are contradictory to what other people are publishing? So if it's against the norm, do you go ahead? Do you go back to the drawing board? What do you do about it? Anybody?
I mean, maybe I'll take this one because mine were definitely quite that. So I think it comes back to what we've said. You have to be confident with the data that you've got. And I think if you're confident with the data you have, it's really important to publish negative results. I mean, publication bias is also an issue, that we only see things in journals that, may or may not, sort of go with our preconceived beliefs, or that are part of the underlying kind of dogma around a particular condition. I think negative results are just as important as positive results. As long as you are actually confident with what you did, then you have to, you owe it to the patients who participated, to the funder that gave you the money for it, the very many, many, many people that were part of the process to publish those results.
Thank you. Another question, maybe if Elissa wants to answer, how do you get patients on board to enroll when it's when you have a research study or a clinical trial site that's naive, that's not really into research, probably doesn't have the resources? How do you increase patient enrollment?
Yeah, that's hard. So I think it's a combination of things, which is, first is that, People have to consent freely. So if they do not consent freely, this is not a negotiation. So there are ways to consent that allow people the autonomy to make the correct decision, and there are ways to consent people that make them feel that if they decline your study, they will not receive good care. And that undermines the project, but it also undermines the patient's trust in the healthcare system, especially among patients who have concerns about research in general and potentially historical concerns about research. So consenting on its own is a unique skill. And I think that that just becomes something that the team needs to agree that you will consent 20 patients and maybe get one who is freely going to agree. And then over time, everyone will get better. And then you can engage other providers, other community members, other care providers of the patient to sort of start to engage them and see if they would be, if you could get more enrollment over time. But yes, just start by asking everyone, learning how to ask better, and let them say no.
Thank you. Those are some important things, especially for us as trainees or early careers, when we think about doing research in a systematic fashion. When you start from scratch, these tools do help. So one more question that I have would be for, there are a lot of questions about statistics. What is a course that people should be doing? Are there any that anyone on this panel has done, like a master's in clinical research perhaps, or an MPH or any other degree that you feel has helped you with your research?
So for people who are in the UK, the course that all of my PhD students, myself, the course that I recommend is at the London School of Hygiene and Tropical Medicine. There's a clinical trials diploma, and that's a fantastic way to also do a kind of part-time course in clinical trials and research while you're also, doing either a clinical job or your own fellowship.
I loved my degree at Harvard. It was a master's in public health degree. And we actually worked with data sets. We did our own programming. We designed research questions. We had practice grant writing. I love degrees where you actually live out the output of that degree, right? You're not sitting in classes and learning things didactically, but you are actually doing and walking the walk as part of your degree. And they were projects during that degree that I published actually, because it was research. So I would say find a degree that allows you to get your hands dirty, allows you to work with others in a group and network, but also fits with what your current status is. So I had a newborn and I would go to Boston with her for a few months in a row, take the courses. My mom would fly out during the weekdays, bring her to be fed, and my spouse would fly out on the weekends. It was sort of juggling, but it worked because I started it during my clinical fellowship. I was given the allowance to do that. It was tougher when I, at the latter part, when I had a faculty position and I had clinical patients to manage and practices to run. In general, I think the upfront investment in a research degree is easier. And believe it or not, fellowship is a great time to be selfish enough to do these degrees because you're given time to focus on it, which you need, especially if you're juggling a parenting role or other complexities in your life. But for some people, the degree might need to be electronic or digital or remote. I would say face-to-face learning is way more fun though. Then there are also smaller programs. Barbara Casady and Oxford has started a master's in clinical trials, and the goal is to get underrepresented groups to really be able to become part of the research enterprise and give people the skill sets to conduct research so that our research questions are broader, more relevant to diverse populations. There's the ACC and AHA run programs, and there's the ACC has Upping Your Research Game, a clinical trials diploma. But I would say a full degree is essential, and there's so many different options.
Thank you. One last question from me, and we'll see if anyone else has any other questions before we throw the floor open for networking. So my question is, are there any unique experiences you've had or unique trial problems that you've faced as a female trialist? Are there anything that perhaps you may not have seen your male counterparts face? And how do you prepare for it? How do you deal with it? What are some tips and tricks you may have?
I would say perhaps never be scared to ask. You know, if you don't know things, or if you don't have certain things clear, just ask. You know, in my experience, I think females tend to be a little quieter than the guys when it comes to clarification and stuff, because they think it's a weakness. You know, they think they should have known that thing. So don't be shy. Just ask. If you don't know, you don't know. There is nothing wrong, and I think it's expected that you're there to learn and to contribute. So don't be shy on that respect.
I've spoken way too much. I have a lot to say about this, and we're publishing something about it. Women are underrepresented in cardiology. They are further underrepresented as research leaders. And there are many reasons why this is the case. One of those reasons is blatant sexism. So we just submitted this week a position statement on the various levels at which sexism manifests itself. For me, the research institute level has been fairly challenging. There are skills and abilities and a persistence that's required to conduct successful trials, to negotiate, to lead. Those skills and abilities don't always fit under gender norms. It is easy to be seen as a threat, to be misunderstood. And in many environments, there is a brotherhood that excludes women, particularly successful women. And you have to learn to navigate that environment. You have to be okay with not being that soft, fluffy, liked person, to be not invited to present at your own institution while you are being invited to present at a global level. You have to be okay with dealing with cement ceilings in your environment and learn how to circumvent those through your activity and engagement on larger platforms. Social media may be one of them. Reaching out to collaborators outside that local environment may be another way to deal with it. Finding alliances with men and women who share your values and share your attention to and passion for research. But there are many, many other barriers that I would say are worth persisting through, right? We know that, you know, adjusting for grant submission quality, if you submit with a man's name, your grant is more likely to be scored higher. This is also true in journals. And this is through multiple layers. And what I would say is, when you are fueled with love for what you do, when you do it with conviction, you are able to navigate through these barriers and find a way to jump even that much higher, to see an obstacle as an opportunity to climb above it, to prove yourself to those on a global level, but also to those at your institution. And then you find that you do things in a way that men wouldn't need to do. You have to predicate things in a certain way. You know, I wonder if one way of looking at this might be, instead of just stating what the analytic plan should be, you learn to kind of soften what you say, to say it with a smile so that you fit in as much as you break barriers. We could spend some time talking about various things pertaining to this amazing question. I'm sure others might want to jump in.
Yeah, as you said, there is so much to say. Should be another webinar altogether. I think, Harriette, I think I share everything you said. I've never been invited to speak in my own institution myself in 11 years in Bristol. And I'm sure, I don't know if Rush and Aaysha might have faced the same, but I won't be surprised if they have also. And so I think there is a reality there.
And I would say for every paper that you have expertise in that you're not invited to participate in as a collaborator, go write your own paper. For every grant you're not included in because the club doesn't consider you part of it, go win your own grant and let your actions speak for themselves. And when I say your grants and your output is currency, I really mean it, because there are some institutions that can be oppressive enough that you wouldn't have anything to stand on if you don't have those building blocks in place. So I say to my trainees, invest in those things that are going to add value and that are going to help you navigate through the barriers that you're going to face after you're outside the cocoon of our environment. For me, sponsoring, mentoring is so important, but the reality is when they leave, they're going to face some of the same things that's out there that we've all faced. And so I think investing in those skill sets is a wise investment, because those things speak for themselves, right? But if you don't have those things to stand on, then you're just a voice.
Thank you. Very insightful. I, in fact, had one of my mentors tell me recently that there is prestige in black and white. So the more you publish, the more people look up to you and you have something to stand on. So with that, thank you for being such an esteemed panel today, for teaching us so much about research, about how to go about deciding on a research idea, how to write a grant, how to go about with this trial, and how to analyze the results that you get. We've all learned so much today. We would want for everybody present here to switch on their cameras if possible, so we can do a networking session and perhaps click some photographs.